This video demonstrates suture cat with iris claw lens. After temporal paracentesis, viscoelastics was injected. NBR is used to create an incision at the trabecular meshwork. Umbrella tipped 50 proline suture is inserted through the inferior paracentesis and is threaded into the Schlemm's canal. Here, stabilization of the globe is important. So, master direct gonioscopy before entering the Schlemm's canal, and it is important to maintain clear visualization throughout the surgery. So there is every chance that you create a false passage.
I'll present today the most important and most objective method of on the step of scleral buccal surgery, that is subretinal fluid drainage. So there is a simplified method which I use, and this is in this. You, after placing the buccal, you take a 2 ml syringe and you take a infusion cannula and place it over the needle and cut at the tip of the needle. So after cutting, take a caliper and measure 3 mm and mark it on the infusion. You will see that the subretinal fluid will drain very easily without any risk of perforating the choroid or perforating the retina. And this method ensures the adequate and complete removal of the subretinal fluid. And this method is also reproducible, and learning curve is too less. And all the instruments are available in our OT. So it is a do it yourself procedure. So there is a complete resolution of subretinal fluid and settlement of retina in all cases done in this method.
Thank you, sir. The next presentation is also by Dr. Jagju.
He always complained of diplopia, so we planned a sclera of SFT, that is fourth row pupilloplasty, to reduce the corneal diameter so that the optic margin of the IOL will be hidden behind. So we planned with the proline suture, that is you have to ensure that there is 4 throws or else the knot will give away. This is the third throw. This is the fourth row. So after that, you pull the 2 ends of the knot, and the pupil will reduce in size and round in shape. And you can it is clearly visible that the optic the anterior is deep and come out. So aseptic pupilloplasty can help in cases of monocular diplopia and photophobia and reduce the glare also in the postoperative period.
Myself Dr. Rakesh Khandelwal, and I am a resident from SC Medical College. So my patient presented to the OPD after trauma, and there was inferior nasal subluxation of the lens was found, and the patient was planned for SICS surgery, but during the surgery we found the zonal laxity was found. So we had to plan for iris claw lens. So here surgical procedure. First, the iris claw lens is placed over the iris and it is rotated to the desired location. We have to ensure that the lens is central, and we try to put some visco and try to rotate. Here we are rotating the lens. We put some visco. So then we insert one side haptics inside the iris using the iris glow IOL holding posture, and we do the same for the other side as well. So we did the same for the other side haptics too.
Bullous RD. As we all know, infusion cannula should be always visualized after inserting it. Sometimes it so happens that the infusion cannula goes behind the retina and causes bullous RD, as in this case. So we took out the infusion cannula from that port and we drained the fluid from the other end. As you can see, the bullous RD has reduced. The infusion cannula was put at the opposite end to stabilize the flow. After the fluid was drained, the infusion cannula was put in the inferior part. After seeing that there was no bullous RD in that point, the surgery was completed and silicone oil was injected. The IOP decreases while doing the vitrectomy. In certain cases, in those cases, even if you have seen the infusion cannula inside also, it might go subretinally and cause this bullous RD. Again, the same thing that we did. We took out the infusion cannula, was put in a other secured position, and then the vitrectomy was completed.
First, we should apply the refined blue. After the refined blue and air with the hydro, we should remove it. Then with the OVD, we should fill the antechamber. The OVD is over the. In case of a run away, do not panic and stop. Inflate the chamber with a good visco and prefer forcefully and pull it opposite. In this image you can see first it runs away, and then in the second image you can see I have made it a flat and then pull it to the opposite side. So in this video we can see in the intuition cataract what actually happens. I filled the antechamber with the OVD, and after that I was trying to debulk the nucleus with the help of the irrigation aspiration centrally. Once that has been achieved, I have applied the visco with the help of the Vana scissor. I am trying to make a newer axis with the capsular axis forces. This is being completed. Now with the help of the hydro, dislodge the nucleus. With the help of the dialer now, and remove it. So the capsular axis in the difficult situations like corticocapsular adhesion, posterior polar cataract, pediatric cataract, anteriorly fused zonal fibers, subluxated cataract, pseudoexposition syndrome, white intermission cataract. So runway is very high in pediatric and anticapsular axis. Always keep chamber deep due to a low scleral rigidity and combined to the extremely elastic anterior capsule. In pseudoexposition syndrome, we can use CTR rings also. Finally, opposite to the side of the subluxation, always use good cohesive elastic and keep the chamber deep. Here I am trying to show you that we will make a smaller axis first. After making of the smaller axis, OVD and complete the axis. Capsular axis is there, two-step procedures are there. Small central opening, or after that a fluid is drained out and then a larger is made. Phaco-capsulotomy, a suck massage technique, there are various methods are there. Newer technologies like femtocataract and zeptocapsulotomy. So I will finish my topic with the last video. This video is not coming. Absolutely.
Good. Then of course I will show you the experience and also what mistake can happen.
So,
हमने देखिए animated video I want to show you. This can happen. And still how we can salvage your surgery.
What I am going to present is from one era to another era of IL of choices. What we have done is we have shifted from premium A to premium IL in small incision cataract surgeries. So in small incision cataract surgeries, what has to be your priorities? In each case, one has to have their own priority set, which has to be tailor-made for individual cases. In each case, suggest and discuss with the patient what you need to discuss with the patient. Discuss their lifestyle, their need, discuss your goals regarding their post-operative vision status, discuss the cost of surgery and the IL you want to implant. Choices of ILs also depends on the resource setting of the particular hospital a doctor is working. In low resource setting, the challenge is to balance between good clinical practice with patient needs, cost and infrastructure. Here PMMA ILs are the options of choice. In advanced resource settings with setups, options for implanting premium ILs are high. Choices of IL. Choices.
Talking about my transition from divide and conquer technique to stop and chop for a beginner phaco surgeon. By beginner. So as you can see, this is a hard cataract. So I begin first with sculpting the groove, and then I try to divide it. But as you see, the central core is still attached. So then I move on to dividing it further, making two grooves which are 90 degrees apart. And I try to divide each into two more quadrants along the sculpted groove. So we make it of 4 quadrants and then move to the emulsification. The cumulative dissipated energy at the end of this case was 21.66. But this is a softer cataract, so I first begin with a narrow, deep and a long trench. My aim is to divide it completely into 2 heavy nuclei. So I try my split first. As you can see, I have begun the splitting. I rotate it 180 degree apart to ensure that the split is complete in its entire length. Then I bring the heminuclei to position and start my chop. I buzz into the nucleus core with maximum power, hold it firmly and then move with the lateral separation by a chopper or a dialer. But as I proceed for the sub-chop, I lose my hold over here, which is one of the challenges I faced because it's a soft cataract and it was difficult. Then I moved on to the other heminuclei and started chopping it into 3 more quadrants. And then began the emulsification procedure. So my CP at the end of this case was 13.32. So the learning point I would suggest is that stop and chop is a better technique. It's a go-to technique for beginner surgeons. And one who wishes to go for phaco chop or direct chop can.
Thank you, Dr. Kiran.
Can you change my... Good morning everyone. So a middle-aged man presented with a open lobe injury with a corneal and with a corneal tear repair. Post-op day 1 AC was flat as evident in ASOCT. Post-op 1 week it presented with a corneal perforation with iris tissue plugged in the hood. So we thought that this was not a regular case, so we investigated the fellow eye, and we can see that the cornea is very thin on slit lamp and even on a pentacam. So we found out that this was a case of brittle cornea syndrome, and we planned for a tuck-in penetrating keratoplasty. The donor cornea was fashioned in such a way that there was a central 8 mm of full thickness corneal tissue with a peripheral frill of 1 mm lamellar tissue to support the otherwise weak peripheral cornea. So we did a So this was the preparation of the donor tissue. Then coming to the trephination of the host tissue, even though we tried to do a lamellar technique and try to make a lamellar plane, but we were unsuccessful, so finally converted to full thickness. And this is the greatest difficulty was suturing the corneal tissue. So the tenonylon had to pass between the donor cornea, the peripheral fringe and the host cornea. So this was pretty difficult, passing a small suture through that, and every time we had to tuck in the peripheral frill of tissue. So this is how it looked at the end of the surgery, and we buried the knots, and from this, with post-operative 1 week, and then the patient is awaiting cataract surgery after removal of after removal of the sutures. So to conclude, brittle cornea syndrome is not a very uncommon condition, even though we may miss it sometimes. Primary closure is advised to achieve anatomical integrity. Conventional penetrating keratoplasty may be challenging, and this is where the tuck-in keratoplasty helps in reinforcing and restoring the strength, structure, and ultimately vision. Thank you.
Everyone, today I am going to case presentation. It's a real case presentation. So an 80-year-old male came in our OPD with a complaint of swelling in right eye since 1.5 years, loss of pain and vision in 6 months. And on ocular examination, it was found to be smooth and inferior nasal displacement of the globe. CT scan report showed an hypodensistic lesion. Oculi is separated and through incision in period vita, orbit has been entered, and a careful dissection has been done to prevent the rupture of the capsule so that the further dissemination should not be happened. And the mass is identified and is removed through the incision. The cornea was also opaque and it has been necrosed, so patient was also PL negative. And there was no chance for the salvation of the vision. So after this encapsulation, removal of the mass, and a enucleation was being performed, a peritomy was being done, and following enucleation is being performed, and the tissue was sent for histopathology report. And upon finding of the histopathology, we found the tumor cells. They have given a benign spindle cell tumor, benign in origin, and they have given a tumor cell positive of S100, and the final diagnosis benign schwannoma of the orbit involving lacrimal gland associated with exposure keratopathy. This is my pre-op and post-op of the patient, and a follow ethical consideration is all being considered. Thank you.
Submitted should also be physically present to be marked for the competition, because this is a competitive session and they should be here. They should value their videos.
It's a huge hole, approximately 1000 micron. After that, the BBG tag was given and PFCL was injected. The eyelid peeling was done with the help of PFCL assistance. After the graft was pulled over, the hinge was still there at the edge of the macular hole. And then it was beautifully placed at the macular hole. Now the fluid air exchange was done very meticulously to make sure that the graft stays in place. This is one of the most important steps, as we all know, in macular hole surgery. SF6 gas tamponade was given. This is post-op day 7 of the surgery, where the OCT image showing ILM graft in place. The boy now has a vision of 6/20, 6/18. Thank you.
It's very valuable and adding value to the entire audience, and we learned a lot about it. So congratulations first of all, and obviously the winner has to win. So let's wait for the results. Thank you, thank you.
Orientation for the surgeon. So how the wound differs from small incision to phaco. The length of external incision is 6 to 7 millimeter as compared to phaco. Width of the channel, we are more anterior into the cornea. Here it is more anterior into the sclera. The internal opening is larger than external, and here it is equal. Side port is made at 9 o'clock and it is made at 2 to 10 o'clock. So the take-home message is our scleral tunnel that we are making, it determines your post-operative visual outcome in terms of visual acuity as well as in terms of non-visual ocular problems with the patient complaints. So a good scleral tunnel, good apposition, and it requires practice. So you should always start with astigmatically neutral scleral tunnel, that is Frown incision to start with, and the practice will make our own more popular. Thank you.
Kindly raise your hand. Whatever difficulties you face, and you just tell.
The right plane and our angulation of the instrumentation is right, but often due to a decrease in sharpness of the available crescents, which could be a manufacturer defect, despite having the right pressure and right angulation of entry, we end up in a buttonholing. Okay, so how do we know that from a very early stage so that we can prevent this complication?
That the blade is not sharp.
So while redefining the incision, most of the time
that is the point when you should be, that the blade is not properly moving. That is, you should not proceed. Try, maybe ho jayega. That is the point you should discard the blade. And previously it used to happen when we were learning. We used to do 10-20 cases in single blade, and that was the credit also at that time. I am with one blade, I am doing 20 cases, but that is not the norm. Now the norm is you have to change blade in every case. Every case, what you rightly said, because of manufacturing problem, you may have this issue. So whenever you feel that the blade is not sharp,
Can you see the blade? So you must see that the blade is seen.
yes.
That means not saying you are going deep. You are going to create a buttonhole. But it's too superficial, upside you will have to. So when you are going there, see that the visibility is there. That is number one. Number two is that you don't push like this. You make a, first of all, create a plane there. That is necessary, that you feel that there is a smooth movement of your blade. So you are creating a plane. Once you create a plane, then it flows. Then you have everything on your hand. If you force it, it will bound to have a problem. Okay?
Thank you, sir.
Placement, detachment. We are using the substituting color. We are using 10-15 cases. We are not changing it. So when you are entering, just feel. Every time you feel. So sometimes you could touch of the instrument or something like the tip of the kerato. Just
which was given in 2025. So there are some differences starting from its definition to its management. Both DUSE 2 and DUSE 3 gave emphasis on loss of tear film hemostasis with symptoms and etiological factors, but in DUSE 3 the emphasis was shifted to multi-driver nature of dry eye disease. Come. In the etiology, again the etiology expanded to 3 main drivers, that is tear film, eyelid abnormality, emphasized with differentiation in the lid abnormality, ocular surface and tear film related problems. The symptom assessment in DUSE 2 was either using a questionnaire of OSDI or dry eye questionnaire 5, whereas in DUSE 3 it was OS 17 was the formulation given by DUSE 2. The newer modalities of treatment like neuromodulation, novel pharmaceutical agents and various phototherapies like IPL and low-level light therapy and plasma treatment were introduced. So coming to the tear supplement, that remains the main cornerstone of dry eye management. It replaces and stabilizes and protects the tear film, and the efficacy depends on the formulation, its molecular weight and preservative used.
कोई भी एक सही आप जो जिसको एक बार प्राइज मिल गया उसको नहीं अलाउ करेंगे. आप प्लीज एक माइक लेके चले जाओ. हाँ कौन सा है कि map is suggestive of irregular corneal curvature. The loss of patient's vision is likely due to higher order aberration. This map clearly depicts a symmetric bow tie pattern which is seen in keratoconus or watercolors significant on this. So which of the following is not a technique? Which of the following surgery is not done to perform this procedure? Sliding knot, sewing machine, single pass 4 throw or iris sensor class. Some surgery has been done for this patient. Which is not a technique for performing this similar surgery? So इंडिया से डिस्क्राइब करा हुआ एक जिनका ये पिक्चर है. What is false? The patient should be started on oral acyclovir and will show response within 7 days. The patient should be started on a combination of antibiotic and antifungal and response will be there in 7 days. The patient should be taken up for scraping, oral vitamin C and doxycycline, which is false, which is incorrect here. Which is least likely or which is false or which is incorrect here. नहीं आप प्लीज डू नॉट प्रॉम्प्ट. आप देखिए, आप देख के करिए. टाइम ठीक है. तो जब हो जाएगा तब मेरे को बताना. हो गया टाइम ओवर. सो एनीवन? सो व्हिच इज ट्रू? It is used for delivering infrared laser pulses in the eye. It operates by vibrating mechanism based on dual pneumatic valve. It has an inbuilt mechanism to reduce chamber instability. It operates at high frequency in order to aspirate vitreous in vitrectomy procedure. What is true? What is correct here? So there is a instrument search. So what is the answer here?
The answer is C.
Chamber stability. Thank you. So इसको aspiration bypass. There is high risk of endophthalmitis. So which is false here? False. Timer 45 seconds का दिया हुआ है. तो यहाँ पे जो भी टेक्निकल डिफिकल्टी है that cannot be taken into account. That is your luck. Which is false. Not correct. False. So do not prompt क्योंकि आपका जो कॉम्पिटिटर है उसको वो सुन के वो आगे चले जाएंगे आपसे. तो ये
PCO because it is a scleral fixated ion, so there would be no PCO.
ठीक है. आप पीसीआर करने के बाद आप बोल सकते हो कि आपका कितना अच्छा पीसी कट गया. इंटरन्यूक्लियर ऑप्थेल्मोप्लेजिया, मीडियल और ब्लॉड फ्रैक्चर. कुछ फोटो है. राइट रेड आपका राइट आई के सामने है. देयर इज रेड एंड ग्रीन. रेड ग्लास राइट आई के सामने, लेफ्ट आई के सामने ग्रीन ग्लास दिया हुआ है. तो ऐसे आपको एक डिप्लोमा चार्ट करा हुआ है. तो व्हाट इज द लीस्ट लाइकली डायग्नोसिस? व्हिच इज फॉल्स? क्या है? लैटरल लेटरल पाल्सी में तो आपका डिस्टेंस बढ़ जाएगा ना. इसमें तो डिस्टेंस बढ़ रहा है. मैं अगर बोलता हूँ ये राइट लैटरल लेटरल पाल्सी है, राइट में डिस्टेंस, राइट में डिप्लोपिया बढ़ रहा है, तो व्हाई इज इट नॉट लैटरल लेटरल पाल्सी? ये तो राइट लेफ्ट लिखा नहीं है ना. क्यों है? नहीं, इसमें क्रॉस्ड है कि अनक्रॉस्ड है आपको देखना पड़ेगा. रेड राइट में रेड है तो ये क्रॉस्ड है कि अनक्रॉस्ड है? क्रॉस मतलब कौन सा ये होगा? स्क्वीन कौन सा होगा?
When the eye is crossed, the diplopia is uncrossed.
Normal retinal correspondence with harmonious ARC, inharmonious ARC with harmonious ARC. मतलब ये दोनों अलग अलग का रिस्पॉन्स सेम होगा. डिप्लोपिया और harmonious ARC और सप्रेशन harmonious ARC. तो किसमें सिमिलर रिस्पॉन्स मिलेगा? Which two people will show similar response in this test? थोड़ा सा रेट ग्रीन ये सब देखो. आपका लक खराब है यार. आप जाके शनि देव का पूजा करना. हाँ संडे है तो बाद में नेक्स्ट सैटरडे कर लेंगे. थैंक यू. प्राइस यस एक्सीलेंट. थैंक यू. विद द रूल और लेफ्ट आई में अगेंस्ट द रूल, राइट आई में अगेंस्ट द रूल, लेफ्ट आई में विद द रूल और बोथ आई हैज with the देखो this is a basic question, so we have kept few questions like which you all need to know. Yes, क्यों? ठीक है. बेसिकली आपको ये समझना पड़ेगा. with the rule मतलब plus at 90, plus axis at 90 is with the rule. ये this is very important. Sir, we have kept very like simple questions so that we all stick to the basics. So we are giving 45 seconds for this. Okay, timer चला गया ना? Technical difficulties के लिए we will not be responsible because that are beyond our beyond your luck. That is your luck. हाँ, ठीक है. Anyone?
Minus 1 sphere and plus 5 cylinder at 180.
Yes, very good. ठीक. Inject or CME. Some kind of IOL intraocular lens has been put in this patient. What is the most likely complication that this patient might have? CNVM, degenerative retinoschisis, macular tail, MAC tail, or CME? पहले लेंस को